All right. Well, today we've got a special treat. We have Dr. Aniket Rali joining us from Vanderbilt University. I just want to take a short moment to introduce Dr. Rali to the group. He was born in Ahmedabad, Gujarat, and moved to the United States in 2003. He earned his bachelor's degree in molecular and cellular biology, as well as in political science from Vanderbilt University. He graduated with an MD from the University of Tennessee and completed his residency in internal medicine from Case Western Reserve University. Dr. Rali completed a fellowship in cardiovascular diseases at the University of Kansas, subspecialization fellowship in critical care medicine at Baylor College of Medicine in Houston, Texas, and then a subspecialization fellowship in advanced heart failure and heart transplantation back at Vanderbilt in Nashville, where he currently resides. His academic interests include critical care cardiology, with a focus on cardiovascular hemodynamics, temporary mechanical circulatory support devices, including ECLS and cardiac transplantation. Dr. Rali currently serves as a member of ELSO's Scientific Oversight Committee and on the Society of Critical Care Medicine's Hemodynamics Task Force Committee. So an expert in many ways about the topic that he's going to teach. And as I had mentioned to our group earlier, Dr. Rali, I had surveyed our group earlier this winter about topics that they may have been interested in learning about, and your talk was in the top 3. So I think people are excited to hear what you have to say today. So thanks for joining us, and please go ahead.
Thank you for this kind introduction and this opportunity to discuss. It's certainly one of my favorite topics to discuss among colleagues. But for full disclosure, I'm no expert in it. But hopefully through this talk, we will all learn together and exchange some ideas that makes us better as a team. So as it pertains to this particular talk, I do not have any disclosures. And my outline for today's talk is going to include discussing briefly the role of temporary MCS in cardiogenic shock, this concept of circulatory support versus cardiac support as it pertains to different devices, including VA ECMO, diving into this controversial subject of is LV venting and LV unloading one and the same? Is all LV venting equal? Furthermore, talking about does LV unloading actually change clinical outcomes? And does the timing of LV venting matter? And then the topic of the hour, which is the unknowns as we move forward in this. So as we know in cardiogenic shock, despite the advancement in contemporary management of cardiogenic shock, the mortality remains high. Depending on what cohort you look at, it's roughly about 50% mortality during index hospitalization. There's limited evidence to support therapies outside of revascularization in those presenting with acute MI cardiogenic shock that actually make a difference, and even fewer options in decompensated heart failure cardiogenic shock, and hence the shift to temporary MCS. The idea being that if cardiogenic shock is a mechanical problem, then a mechanical solution in the form of temporary MCS is what we should be providing for these patients. The 2 main goals of temporary MCS in cardiogenic shock include 1, restoration of perfusion, which is the circulatory support, and 2nd, ventricular unloading, which is the cardiac support. No conversation on cardiogenic shock and temporary MCS is complete without a similar looking slide where we discuss the whole host of temporary MCS devices that provide varying degrees of circulatory and cardiac support, starting all the way from the left with the intra-aortic balloon pump to the one on the right, which is the VA ECMO. While VA ECMO provides the most comprehensive form of circulatory support, it carries its unique challenges when it comes to cardiac support. Given its comprehensive circulatory and pulmonary support, VA ECMO has grown in popularity over the years. This is our analysis of the national inpatient sample. And as you can see, between the years of 2007 and 2014 in the United States, across all different etiologies of cardiogenic shock, the utilization of VA ECMO has gone up. Again, as I said, this is national inpatient sample database that is analyzed here, but similar trends have been documented across other registries as well. Furthermore, given the findings of the CHEER trial from 2014 and the ARREST trial from 2020, ECMO is also now globally being used more frequently during cardiopulmonary resuscitation, this concept of ECPR as we have come to know it. So VA ECMO, as we know, there are several components to this circuit, and most of us on this call are very familiar with the various components that go into this circuit. It is postulated in part that the deleterious effects of VA ECMO on the ailing heart result from the fact that it relies on retrograde flow through the aorta to circulate, to provide circulation, especially proximal to the outflow or the return cannula. This is most pronounced in the peripheral configuration that you see on the left, but also to a lesser extent happens in the central configuration. So we know that VA ECMO provides retrograde flow, but what are the actual hemodynamically relevant effects of this retrograde flow? And what we see from it is that it increases LV afterload, it increases the pressure across the aortic valve. So the transaortic valve gradient is higher, and both of these result in decreased aortic valve opening, decreased LV ejection, which then subsequently results in increased volume and distension of the left ventricle, and also increased left-sided filling pressures in the form of pulmonary capillary wedge pressure as well as your LVEDP. And the net result of all of this is that you are left with lower pulse pressure, especially in patients that have the ailing myocardium. As a result of the increased LV pressure and LV volume, the PV loop in these patients that go on VA ECMO configuration actually moves to the right. And as we will see a few slides later, that this has profound implications as far as your myocardial oxygen consumption is concerned. So now we know that VA ECMO increases your LV afterload, and that causes hemodynamic consequences. But what are the clinical consequences of an increased afterload, especially as it pertains to an ailing myocardium? And they are not limited, but definitely include myocardial ischemia, delayed ventricular recovery, ventricular arrhythmias that may result from the over-distension of the LV, pulmonary edema that results from increased filling pressures on the left side, decreased aortic valve opening, and hence decreased emptying of the LV can then cause thrombotic events both in the aortic root as well as in the LV itself, and ultimately progression of the cardiac failure to multi-organ dysfunction that results when all of these happen in a sequential fashion. We know from prior studies that when you look at the PV loop, the area under the curve of your a slope of contractility, which is represented up here as ESPVR, and your area of relaxation, which is represented up here, which is the EDPVR, which is often referred to as the pressure volume area. This corresponds directly with myocardial oxygen consumption. When you think about what is it that the heart needs the oxygen for and where this oxygen is deployed, a lion's share of the oxygen consumption goes into mechanical work of the myocardium. Hence, in cardiogenic shock, when you unload the ventricle or when you take over the mechanical work of the ventricle, that's how you reduce the myocardial oxygen demand. In the case of VA ECMO, as we saw in previous slides, the exact opposite happens. It leads to increased myocardial oxygen demand because it increases the mechanical work of the ailing myocardium. And this, in my biased opinion, is why LV venting is absolutely critical. So once LV venting devices go in, or whatever you may use for LV venting, the ultimate goal is to not just reduce LV pressure, but also LV volume, shift the PV loop back to the left. And as a result of that, which then is a reflection of you reducing the myocardial oxygen demand of the ailing ventricle. That brings us to this important question of whether LV venting and LV unloading are one and the same. And the short answer is no. So LV venting refers to passive or active decompression of the ventricle, versus LV unloading refers to more active reduction in ventricular mechanical power expenditure, myocardial oxygen consumption, and the hemodynamic stresses. And the perfect example to demonstrate that is that of inotropes. So as you see in this hemodynamic modeling, that inotropes, while they may help, quote unquote, empty the LV more effectively, they also contribute to increased contractility and hence increase the myocardial oxygen consumption of the ailing ventricle. In contrast to inotropes, vasodilators may actually have beneficial effects in actually reducing the LV afterload on patients that are on ECMO. Intra-aortic balloon pump is tricky in some ways because of its counterpulsatile fashion, but it also seems to render a marginal benefit. While the most profound benefit seems to be coming from surgical LV venting, as well as trans-aortic valve venting that comes in the form of percutaneously placed devices. Another interesting concept is that of creating an iatrogenic ASD to then serve as a pop-off valve for the increased left-sided pressures to decompress into the right side through a left-to-right shunt. What is modeled here is a fairly large ASD that often requires closure after the patient has been weaned off VA ECMO. However, what our group was able to show that a similar ASD or a smaller ASD may also be beneficial. So in this case series published by one of our fellows, small sample size of 12 patients that are all on peripheral VA ECMO that were taken to the cath lab, and then using a 15 millimeter balloon, they were a transatrial septostomy was performed, creating a small ASD to allow, again, as a pop-off valve for the increased left-sided pressure to then go into the right side. The advantage with this is that, keeping in mind that the VA ECMO, while it increases your LV afterload, it does a phenomenal job of decongesting the central veins. And what we were able to show in this case series is that there was a statistically significant reduction in left atrial pressure from a mean pressure of 21.8 before the septostomy to 15.9 after the septostomy. And in this cohort, there were no procedural complications compared to the 9.4 that has been reported in other studies. 4 of our patients in this cohort ended up being bridged to transplantation, 1 being bridged to LVAD. And the overall survival to discharge in this cohort was 58%, which is pretty much at par with cardiogenic shock outcomes in a lot of ways. So hemodynamic modeling is great. A conceptual framework is helpful, but what every clinician wishes to know is whether LV venting alters the clinical course and can it ultimately improve outcomes. My biased opinion is yes, but the honest answer is that it remains to be seen. We're all probably familiar with this meta-analysis that was published in JACC a couple of years ago by Russo et al. That looked at 17 studies and close to 4,000 cardiogenic shock patients on VA ECMO. The overall mortality in this cohort was about 60%. And what they found is that your relative risk of mortality during index hospitalization, if you did receive LV unloading, was 0.79, and that was statistically significant. Additional key aspects of this analysis were that it did not include any randomized control trials, and 85% of patients analyzed in this cohort had preemptive LV venting, i.e. prior to VA ECMO or immediately post. This is going to be important as we discuss over the next few slides, whether the timing of LV venting matters. Additional findings of this study were that there was no interaction between the specific LV venting unloading modality, i.e. intra-aortic balloon pump versus peripheral VADs, similar to Impella and others, and the association between LV venting and mortality. Also, there was no heterogeneity in this association based on the etiology of cardiogenic shock. Around the same time as this article was getting published, our team was also analyzing the national inpatient sample to ask the exact same question. And what we found in our sample of patients between 2007 and 2014 is that a very small percentage of patients in the United States that do get ECMO for cardiogenic shock actually receive any form of LV venting, only 24% in our cohort. And a lion's share of those that do receive LV venting receive it using intra-aortic balloon pump, which is 84% in the cohort. What we found in our cohort is that there was no difference in mortality between those that received LV venting and those that did not receive LV venting. A major caveat that differentiates our findings from the Russo meta-analysis is that 100% of patients in our cohort received LV venting as a bailout strategy. None of them had LV venting in place prior to VA ECMO configuration. And as I said, 84% or so had LV venting in the form of intra-aortic balloon pump. So that left us pondering, perhaps, if the focus should be on preemptive rather than bailout LV venting, and should it be on comprehensive rather than partial LV unloading. After all, prevention is better than cure. However, is there any evidence to support this? And what about the complications that result from LV venting devices? That brings us to the stop shock registry analysis of this trial, where 686 cardiogenic shock patients across 16 centers in 4 countries were analyzed. These were patients that were enrolled in this registry between the years of 2005 and 2019, and then retrospectively analyzed and categorized into cohorts of VA ECMO versus ECMO, where you have VA ECMO plus Impella arms. The only exclusion criteria was if you were younger than 18 years or if your cardiogenic shock was post-cardiotomy. And the primary endpoint that they looked at in this study was 30 days mortality from all causes. And what they noted in their unmatched cohort, as you can see on the graph on right, is that your risk of mortality within the 30 days after being on VA ECMO was statistically significantly lower in those that received ECMO. As you can further see that in the unmatched cohorts, those that received ECMO had a higher percentage of non-ischemic cardiomyopathy, were more likely to have received ECMO as a part of ECPR, and had a higher predicted mortality during index hospitalization based on their pre-ECMO baseline SAFE score. In other words, these are sicker patients in some ways that are being put into the ECMO arm. The results were consistent and even more convincing when you actually matched the 2 cohorts, and they were matched for age, gender, cause of cardiogenic shock, previous cardiac arrest, whether they received ECMO as a part of ECPR, what their baseline MAPs were, what their baseline heart rates were, and what their baseline lactate and pH were. And as you can see on the plots on the right, that this benefit seems to be across all subgroup analysis, some more than others, but it seems to be throughout the cohort. That brings me to the question of what about the complications? The most common complications that they noted in the ECMO group was severe bleeding. And as you can see, consistently in the ECMO group across all subgroup analysis, there's a higher likelihood of severe bleeding, perhaps the most severe being in those that are older than 62 years of age. But important conclusion of this study was that despite this higher rates of complications that come from additional devices, they were able to show consistent mortality benefit at 30 days. And it's also important to note that when you look at complications that come with this additional devices, the role of survivorship bias, i.e., you're obviously going to have more complications in those who live longer rather than who die more rapidly. So there is that time-dependent role of survivorship bias when you're looking at complication rates. What about the timing of this? So they did subgroup analysis in their cohort, and what they found is that when you look at early versus delayed LV unloading, and they defined early as either preemptive or at the time of VA ECMO cannulation or within 2 hours of post-ECMO cannulation, that most of the mortality benefit that you saw in the previous slide seems to be coming from early LV venting and less so from the delayed LV venting. But then you say, what about that other study that showed that these results are not consistent? Well, LV unloading in VA ECMO is a clinically important topic that is starting to deserve a lot of attention, as it should. But this also translates into several single center experiences being published with varying conclusions. And I know I'm preaching to the choir when I say we have to be very careful how we interpret these conclusions of these studies. Here's one example. Take a look at the single center study, and this is directly copy pasted from their abstract. Their discussion says, based on this analysis, reactive unloading, which in other ways is bailout unloading, appears to be a viable strategy while venting with the Impella CP provides better than anticipated survival. Our findings correlate with recent large cohort studies and motivate further work to design clinical guidelines and future clinical trial designs. In this study, they looked at only 63 patients. They divided them into 2 groups. Group 1 was the reactive unloading, and group 2 was the immediate unloading. Your trigger for those in group 1 to decide on going ahead with LV unloading strategies was that if you noted that their pulse pressure was less than 10 millimeters of mercury while on maximal VA support and on inotropic support or as tolerated inotropic support, Then you decided to go ahead and do reactive unloading in these patients. And the primary outcome that they looked at was 30-day mortality. When you first look at this graph, and when you look at the bottom line of this graph, you say that there's no statistical difference between the two arms. But if you look at it, there is still a 9% higher survival in those that received immediate venting. Now put this in context of what the mortality in cardiogenic shock is. Keep in mind that these are extremely sick patients in cardiogenic shock. So if you believe in the SCAI staging system, this would be SCAI stage E of cardiogenic shock that are requiring VA ECMO, that have a predicted mortality in excess of probably 50%. And now you're saying that for every 100 patients that do receive LV venting immediately, 9 of them are more likely to survive. So this becomes a clinically relevant question and asks and begs the question whether this study was just simply underpowered for you to show the statistical difference, but there is sufficient signal that immediate venting is important. Furthermore, when you look at the data based on what strategy of LV venting was used, Impella versus balloon pump, look at how it changes the predicted survival to discharge. So your predicted survival in the Impella group, although a very small sample size, based on the baseline safe score is 18%. That goes up to 37% after the Impella goes in. So, and this should come as, again, no surprise to anybody else, because at the start of cardiogenic shock, this is a circulatory problem. So when your therapy is to provide that circulatory support, but as you accumulate more time on the VA ECMO, if you're not supporting if you're not providing adequate cardiac support as well, you run the risk of this evolving into a hemometabolic problem, in which case then a circulatory support alone is not going to be sufficient. Then ultimately, in a time-dependent fashion, the patients continue to do worse without adequate support. In this review summarizing available literature on LV venting in VA ECLS patients, we proposed a very basic algorithm on timing of LV venting based on what the ECLS support is a bridge to. And what we proposed is that if the ECLS is being used as a bridge to recovery or as a bridge to decision, then these patients should have early, i.e. preemptive LV venting in place. For those patients that have a definitive exit strategy in the form of LV venting, in the form of an LVAD or heart transplantation, the decision to provide additional LV venting or not should be based on anticipated duration of ECLS support. The major caveat to this, and that's why there's an asterisk there, is that you never want to wait too long where you have evolved from it just being a cardiac problem to a cardiopulmonary problem, where an LVAD or a transplant alone will then not suffice. So it's a delicate balance. We also recommended that a combination of both hemodynamic and echocardiographic parameters should be applied to assess the effectiveness of LV venting strategy and unloading of the LV. We all know that pressure and volume are not the same. The decision to target a near normal wedge pressure with LV venting is based on some computational studies that have modeled LV distension on VA ECLS. There still remain a ton of unknowns and unanswered questions when it comes to LV venting in patients that are on VA ECMO. The first one is, can artificial intelligence analyze large granular data sets to help precisely identify patients and triggers that warrant LV venting? Can we use gene expressions, proteomics, to help identify how early in the VA ECMO support does the adverse remodeling begin? Can that help us to decide the timing of LV venting? Are there certain patients who are genetically predisposed to adverse remodeling? This is actually one of the questions that our team is currently working on, trying to develop a large animal model to answer how soon do we start seeing gene expression differ in the LV once it is subjected to the afterload that comes with VA ECMO. What is the ideal time for LV venting to be weaned? Should it be never? In other words, should you always be in the VA ECMO first and then the LV venting follows? How do all of these questions apply to specific etiologies of cardiogenic shock? We all know that acute MI cardiogenic shock is a completely different entity as compared to decompensated heart failure, as compared to myocarditis leading to cardiogenic shock and requiring VA ECMO. And ultimately, are there certain hemodynamic variables that should then prompt us to deploy LV venting? And along the same lines, we analyzed a cohort of about 2,400 patients using the ELSA registry. And in these patients, the overall mortality in this entire cohort of 2,400 patients was 49.5%. And what we found consistently is that as early as 24 hours after the VA ECMO support is initiated, if you see an improvement in your pulse pressure, then that predicts improved mortality during the index hospitalization. So perhaps if you do not see an improvement in pulse pressure, or if you see a worsening of pulse pressure despite VA ECMO configuration in the first 24 hours, then maybe that should be the hemodynamic trigger for you to then help the myocardium out with LV venting. This is another question that we are in the process of analyzing using the same registry to see if LV venting in those that do not have early predictors of myocardial recovery, or do they benefit? Again, this is a retrospective analysis of a large database, so take it with a grain of salt. But this work is currently submitted to Jack Hartfield, and hopefully with our revisions, it will be accepted. So what are some of the take-home messages that we can take from this? One, VA ECMO is excellent for circulatory support, but it's tough on the ailing heart. Second, not all venting unloads the ventricle equally. Third, early and comprehensive rather than late and partial venting or unloading of the LV seems to be what matters most in kind of shifting the needle to better outcomes. Clinical, hemodynamic, or biomarker triggers that should prompt LV venting in LV unloading in those that do not have preemptive LV venting in place remain unclear. And there remains a paucity of randomized controlled trials to support preemptive LV venting, despite the hemodynamic quote unquote common sense that that should be efficacious. That is all I have. And again, I greatly appreciate this opportunity to be able to discuss some of my thoughts with you guys and look forward to our discussion.
All right, well, thank you so much. That was a wonderful talk. I've got a number of individuals on the call here today. So anybody, if you have a question for Dr. Rali or a comment that you would like to make, please feel free to jump in or raise your hand and I'll call on you.
Dr. Rali, Sam Hahn here, interventional cardiologist. That was great, a great summary of everything. And I think, you know, what my take-home messages from this was that I think people be more enthusiastic about LV venting if we could do it well. You know, I think your slides and your presentation indicate that we don't really have a good strategy or a good device for it, right? I mean, Impella is by far from a perfect device. We've had lots of issues with it, you know, for even intermediate term use. Certainly, I can't imagine someone being stable on Impella for more than, you know, 5 days, bleeding complications, ischemic leg complications. Your balloon septostomy approach is you know, interesting. Where do you see, you know, development of devices down the road for LV venting? I mean, I've actually talked to a few companies to see if they have any interest, and they've had none. So I think we need some innovation in this area, but it seems to be pretty stagnant.
I couldn't agree with you on multiple fronts. I think part of the hesitation with preemptively venting the LV with an Impella or other devices is the fact that these devices are not perfect and would come with their own complications. The counter to that is that it's reassuring that despite accounting for these additional complications in really sick cohorts, as we have seen in some of these retrospective analysis, that there seems to be a mortality benefit that is offset despite the complications. This comes up all the time in our ICUs with residents, fellows, my colleagues. We always talk about what is the perfect device. And unfortunately, until that perfect device comes along, what I like to think of is that we have to get better at matching the patient with the device. The devices in due time will get better as they have over the years. And until then, identifying which patient's substrate is at the highest risk for decompensating just on VA ECMO, and then deploying these devices, understanding that we're going to accept that higher risk might be the game changer. I have met with the same resistance that you have talking to device companies about these trials, because there's always that fear: what if the device doesn't improve outcomes? Then you're kind of in a tough spot. But to your point, I think my bias, again, and it's a biased opinion, is that and it partially comes from my critical care background. When we decide that somebody needs to go on mechanical ventilation because of respiratory failure, we don't intubate them and put them on minimal support and then escalate if they continue to decompensate. So I think by the time a decision is made that somebody needs to be on VA ECMO, one thought could be that you just provide them with maximal support and then rapidly wean them rather than escalate if they continue to get worse.
Dr. Patel has his hand up.
Hey, Aniket, great talk.
Thanks.
One thing I always wonder is, in absence of patients who have no signs of distension, arrhythmias or congestion, now two subsets of patient, one acute MI and post-cardiotomy shock, who you're expecting recovery rather than a patient who are on ECMO as a bridge to VAD or a transplant. Now, again, this is biased, but I think the patients you're expecting myocardial recovery and come off ECMO, what are your thoughts that should they be just ECMO plus vent, so you have true unloading, rather than wait for the other two groups where they're bridged to VAD and a transplant regardless. So even if there is some sort of distension, it should be okay.
So I think that's the $1 million question, right? Like, again, it goes back to what should be your trigger. And I think if you're seeing signs of distension, then I think it's, regardless of your end game, your exit strategy, I think you should vent. The other thing is, how are you monitoring your variables for distension? Consistently, I mean, I am fortunate, I've trained at 4 different institutions before I settled down at Vanderbilt. And there's a lot of, even within the 4 places that I've trained at, there's a lot of discrepancy in utilization of SWAN-guided hemodynamic profiling of these patients, right? A lot of times, our surgical colleagues here, even at Vanderbilt, are hesitant for us to go and wedge these patients because they're fully anticoagulated and the risk of pulmonary rupture is not trivial. So that being said, in the absence of us reliably knowing whether we have truly decongested the LV or not, sometimes the echo can be misleading as well. I mean, there was a recent article in Journal of Cardiac Failure, which nicely demonstrated that volume and pressure are not the same thing. When we don't know what the left ventricular compliance is, that even what may look like very decongested LV may still be compromising your coronary perfusion flow because your filling pressures are high in that sense. So I think that's partially the challenge. But if you have consistent hemodynamic monitoring that tells you that your wedge pressure is, say, 12, 13, then I think it's reasonable to just kind of monitor that. But in the absence of that, I think it's in some ways dangerous for it to kind of the patient to clinically declare themselves and then go ahead and LV vent them. But obviously, both of us share similar biases because we are trained by similar people at Baylor. But along the same lines, I think even in those that you have a definitive exit strategy, making sure that the rest of the body is protected is, I think, very, very critical. Anecdotally, all of us know patients that were waiting for an LVAD and then the pulmonary mechanics got worse and then the RV started filling and all of a sudden they were no longer an LVAD candidate. So I think it's waiting is good as long as it's very watchful.
Anybody else? Please feel free to jump in. See Matt muted himself.
Yeah, hey, Dr. Rali, thanks. That was a great talk. I just had a question about kind of what you saw challenges being with an RCT, looking at early venting versus more conservative strategy, or if anything's in the works for that.
So there is one excellent question, right? So I was just talking to some colleagues in Germany last week about this, and they have some national level funding to be able to look at this exact question in a randomized controlled trial setting. A couple of questions came up as we were discussing. What is the first thing you randomize the patient to? Should it be LV venting versus not venting, or should it be different devices and see which device is more efficacious, right? So that is another area where I think there were 4 of us on the call and we had 16 different opinions as to what the first randomized control trial should be. I am biased that it should be early and comprehensive. So you should, and then if you demonstrate that in a randomized control trial with comprehensive and early LV venting, then all subsequent trials should be non-inferiority trials and go from there. that something else that is less invasive or easily deployed is just as good. But that's the issue, and the same issue holds true in any kind of shock, right? In the critical care world, there are hundreds of randomized controlled trials that come up in the septic shock world, and a lot of them are not consistent not because they're poorly designed trials, but this is such a heterogeneous group of patients. What works in patient A, although they have the same hemodynamic profiling as patient B, may not work in patient B. And I think that's where some of the roles of proteomics and stuff like that, looking at who it is that is more vulnerable than the next patient, is going to be interesting. But the biggest challenge, I think, is that this is a patient population that has a very high risk of mortality. They are obviously critically ill, and randomizing them, it's challenging because you just don't have enough time up front to actually get an informed consent and then randomize them. And then how do you not prevent crossing over, right? You may randomize somebody, but if you obviously see somebody getting worse and they don't have LV venting, how do you then go to the family and say that I'm not going to allow crossover because it affects my study outcomes? So these are, I think, just some of the reasons why a lot of people keep going back to retrospective analysis, although all of us that do database analysis and retrospective studies very well understand at the core of our heart that this is not definitive evidence. This is at best hypothesis generating, but definitely not definitive. But to your question, yes, there are things that are in the works, and hopefully people that are more courageous than me and smarter than I am will be able to lead the front on this randomized control trial.
Oh, thanks, appreciate it. Yeah, I think it's so difficult to match these patients in retrospectively, just even with quantitative matching or more advanced propensity matching scores. That, yeah, it seems interested to see what that turns out. But thanks again.
Can I just add a quick thought on this LV venting?
Labi, you went mute.
Sorry, can you hear me now? Yeah, I think I'm unmuted. So if we are going down that RCT route, I wonder if we should, for this particular question, not use mortality as an outcome measure. These patients, as we all know, all have very high mortality to begin with, and with so many confounders. I wonder if we look at reverse remodeling, length of stay, risk of pulmonary edema, these kind of things as an outcome might hopefully reduce the sample size.
No, I think that's an excellent point. The only challenge with that is we have been able to show that these devices change the hemodynamic profiling, right? Like in the sense that you can have a swan and you can put in an impella and show that their wedge pressure or their SVO2 or whatever other hemodynamic variables you look at, that those kind of intermediate outcomes do change. You can also look at, there are some trials that are ongoing or are in the works, I think, with impella alone as a platform for myocardial recovery, and looking at stuff like liver decongestion, looking at urine output in these patients over 24, 48 hours and stuff. But ultimately, I think in order for us to make this universal practice, invariably it keeps coming back to, do these patients live better? But I 100% agree with you. I think as intermediate steps, that would be the first things to look at. For full disclosure, I'm not involved in this randomized control trial. It's just that people that I work with on different projects are the ones leading the front in Germany. And so I had kind of just called them to pick their brain about some stuff. But I agree with you that maybe doing a smaller randomized control trial, looking at hemodynamic and other end organ perfusion parameters, such as lactate clearance, such as what does your vasoplegia do? What does your inotrope scores do when you do this? What does your pulse pressure do? Maybe using those variables early on, and then if there's a signal there, then kind of doing the larger follow-up and seeing if it changes your 30-day mortality. But I mean, I'm biased in that sense as well, because if somebody came to me and said that their SpO2 is better at 24 hours, or if the need for inotropes is less at 24 hours in those that have entered, the first question I would ask is, but do these patients live longer, right? So I think ultimately that's where we have created this issue and within the world of cardiology, that we want everything to change mortality.
Is there anybody out there with one last question as we're getting to the top of the hour? Well, if not, I guess we'll wrap up. So Dr. Rali, thank you. That was a wonderful talk, and you know, a lot of enthusiasm here from the group about having you join us today, and we learned a lot. Thank you so much again, and hopefully we get to meet sometime down the road.
Yes, absolutely. Thank you so much for having me. And again, this is an ongoing conversation, so please feel free to email me, text me, other ways. I would love to hear everyone's thoughts, because that's how I continue to learn.
Thanks so much.
Thank you.